from this podium, and so is the Lieutenant Governor and the Secretary, is that the knowledge base around COVID is one that continues to evolve. And in some cases, it runs in exactly the opposite directions within a week or two. For example, there was a study that was put out about 2 weeks ago that got a lot of attention that said gaiters were not effective, or were not as effective as face coverings. A week later, there was a study that came out that said gaiters, in fact, were as effective as face coverings. I think the message that we took from all that is if you hold it up to the light and you can see through it, it's probably not very effective. There were studies about whether there was asymptomatic spread or not that went on for months until people finally landed on the idea that it's pretty clear there's asymptomatic spread, and then there's some debate about whether it's 20% of the cases or 40% of the cases. And one of the biggest areas of debate and discussion has been how much of the asymptomatic spread involves kids. When I say kids in this case, I mean sort of anybody under the age of 30. I think from our point of view, one of the reasons why we spent so much time with the infectious disease community and the pediatric community in developing our criteria and our guidelines with respect to school reopenings was because of concerns that some of this data is still evolving and we don't always know the answer. And that's why the rules around transportation, the rules around distancing, the rules around desk configurations, the rules around masks, the rules around sort of all the elements associated with in-person learning were worked on pretty hard and developed with a pretty broad panel of experts before we put it forward. The other thing I would say is that if you have a commonwealth in which you have 351 cities and towns and 300 of them basically don't have a heck of a lot of COVID, there can be a fair amount of confidence in those communities that a hybrid model or some version of hybrid plus in person can be a workable model that can be done safely.
Governor, can you explain on the rapid mobile testing, how will that be launched in the schools, and then how will the...
It would actually be launched, it wouldn't be launched in the schools. It would be a real resource that would be available to the schools based on some of the criteria that the Secretary walked through.
And how would contact tracing work within the school? Would it be the same way? Would they, the same parameters, kind of, 15 minutes, 6 feet, and then try to keep kids out of the school if they become contact traced?
You mean as close contacts?
Yeah.
I think
how will the contact tracing be done in the school?
I think it's going to be done the same way it's done now, which is the outreach would be to the family or the individual who tested positive, and then the follow-up would be with any of their close contacts who could be kids in school, but who could also be, the kid who came over and watched the movie who lives next door. I mean, there's a lot of other possibilities there, but the model would basically be the same.
So will schools have to request the rapid mobile testing program to deploy to their school? And also, you said K through 12, are you looking at this for colleges to be able to access as well?
I think we're thinking mostly about K through 12 on this. The colleges, I think, have their own expectations about being able to use their own health services for that type of stuff. And many of them have signed up with the Contract Tracing Collaborative and with the local boards of health to do the work for them associated with tracing cases in colleges. With respect to the mobile testing, the mobile testing capacity itself would basically be ordered by the local Department of Public Health in the district in which the school was located.
Would kids get tested before they then proceed into school, or is this something, because it is 15 minutes, I'm just kind of trying to figure out how it would work, what it would look like.
You want to speak to that?
So as you know, the CDC does not recommend testing for students and staff. So we see this as a response to schools concerned about cluster development. And so if a couple of, so I'm just going to, let me just say like 2 teachers, are a teacher and a student in a classroom, both within a 14-day period, were to become symptomatic with COVID and tested positive, that the local Department of Public Health, the local Board of Health, and the school could say, we're concerned that this classroom may have transmission going on, and they could request the rapid response team to come to the school. Obviously, if for students to be tested who are in that classroom, parents would have to agree, right? You have to have written consent of parents, but we'd make it available for schools to have testing done. We see it as sort of an abundance of caution of being able to do, just like we do now, we have stopped the spread in 20 communities. Anyone who's asymptomatic, right, can go be tested. So we see this as a response to school concern that they might have a clustering development within the school, within a cohort in a classroom, among teachers, or a couple of kids on a bus. So we see this as a way to deploy, right, just like we did in nursing homes. All right, we come to you in the event that you believe you have a cluster, and obviously everybody who has a runny nose, right, we're not going to come out. So there has to be some parameters involved, which is why DESE and the Department of Public Health will put out some greater guidance on sort of how to request this. But we will have the capacity by the end of August of a statewide mobile response team. The RFR is active right now, and there's been a lot of interest, just like when we tested it out on the nursing home side. So it's that kind of being able to come to the school in response to concern. And clusters defined as 2 or more non-related individuals within some kind of contained
Are you
space.
concerned about accuracy, though? There was reports that there were some false negatives with these, and you should take...
So this is PCR testing. So, right, this is diagnostic testing. This is molecular testing. This is not, I'm looking forward to when we have true surveillance ability in the Commonwealth of Massachusetts.
Secretary, can you...
Governor, you may have heard the teachers' unions were rallying out front here yesterday. I don't know if you were here. They are saying they may refuse to go back to school because it's unsafe and it's putting their membership lives in danger. Are you concerned that towns may have to hire replacement teachers if they don't go back?
Well, I'd say 2 things about this. One is the guidelines and the criteria that we developed in conjunction with, it's actually mostly developed by the folks over here, the command center and the folks at DESE. That work was done in conjunction with epidemiologists, infectious disease specialists, and the pediatric community. And that's why the American Academy of Pediatricians here in Massachusetts endorsed our proposals. I think in many ways, people are using what I would describe as the best science to develop appropriate plans and standards to implement this. And I think it's anticipated and expected that people will teach. I mean, do you want to speak to this question, Commissioner? I mean, it seems to us that based on the dialogue and the vibe that we've gotten, there's always going to be some back and forth, because there always is, over any kind of change in criteria associated with sort of the opening of the school year every year. But I think it's our expectation, especially in those communities that really don't have a heck of a lot of COVID at all, and where the rules and the guidance around hybrid and in-person learning are pretty well developed and have actually been in place in other countries, in many cases for a significant period of time with limited impact, that this shouldn't be an issue for people.
They're saying that they want routine testing in the schools, not emergency testing, rapid response, and they want every school building certified as safe by the state for HVAC, etc.
So I would urge everybody to take a look at the statement that was issued by the Amherst Pelham School Committee in response to the demands of the teachers union and their community. They make a very strong case that the guidance, criteria, working environment, all the rest of the elements that they put forward were completely consistent with the science and advice and guidance that's been issued by the national players in this space, as well as in some cases the global players, and that some of the issues that were being raised by the union just don't even make any sense. I think in many ways, I respect and understand the importance of making sure that this be done safely, but I would also ask people to respect the science, which at this point is developing a fairly decent body of evidence with respect to what works and what doesn't when it comes to teaching in person. I mean, we've had special ed schools that have continued to teach all the way through this, and we visited a few of them, and kids are wearing masks, instructors are wearing masks, and the programs are basically working, and they've been working, and they involve a lot of close contact when you're talking about special education. This can be done, and as I've said before, We need to commit to the science. We believe we have, but we also need to commit to the kids. One of the reasons that so many people in the mental health and pediatric community are deeply concerned about this continued approach to remote learning, which in many cases last spring, I think everybody would agree was really not learning at all, is a really big issue.